Good afternoon. Welcome and thanks for joining us for today's HIS Talk webinar, A Sepsis Solution, Reducing Mortality by 50% Using Advanced Decision Support. It's brought to you by Wolters Kluwer. I'm Lori from HIS Talk and I'll be moderating. I have a couple of housekeeping items to make you aware of before we start the webinar. Attendee phone lines have been muted to prevent background noise. Please use GoToWebinar's questions box in the console to submit questions to our presenters at any time. The presenters will answer your questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a link to the recording as well as a PDF version of the PowerPoint presentation in a follow-up email. We have two speakers today. First, we'll hear from Stephen Claypool, MD. Dr. Claypool is the Medical Director of Innovation Lab at Wolters Kluwer. Joining Dr. Claypool will be Rick Korn. Rick is the Vice President and Chief Information Officer at Huntsville Hospital in Huntsville, Alabama. And with that, I'll turn it over to you, Dr. Claypool.
Thanks, Lori. Rick and I will actually toggle back and forth a few times during this presentation. So sepsis, I like to describe sepsis as the most important medical condition that many people have not heard of. It's not quite as well known as heart disease or cancer, but it is a very important disease in this country and worldwide. It is one of the #1 causes of death in intensive care units in the country and is one of the most costly medical conditions. And perhaps more importantly, care for sepsis tends to be suboptimal at almost all healthcare systems around the world and even around the country. The care could be significantly improved, and that's one of the reasons it's a focus for us for decision support. Rick?
Here are a few of the key statistics that will provide you a frame of reference for the size and complexity of Huntsville Hospital. We're a tertiary referral center serving the Tennessee Valley. We're the second largest hospital in Alabama with a little less than 1,000 beds in our primary facility. We're the 5th largest publicly owned health system in the country. The project that we're going to be talking with you about today started as a pilot on 3 nurse units. Today we have 10 units that are live on the point of care advisor application, and we have 6 more units that are scheduled to go live in the first quarter of 2016 with other nurse stations that will follow that as well. By the time we began our work with Wolters Kluwer, we had identified reducing sepsis mortality and severity as a priority for the organization, and we'll get into that a little bit more in a couple of moments.
So this is data from before the engagement with Wolters Kluwer with Huntsville. It's data collected 2 different ways by the quality teams at Huntsville. One method is using the Surviving Sepsis Campaign definitions for sepsis, and the other is for just using the discharge for patients that have a complex series of sepsis infection-related codes. You can see there are quite a few different ways to assess for the prevalence and mortality for sepsis, but using either of these methods, you can see that Huntsville's numbers were higher than national averages. This is one of the reasons for both lengths of stay and mortality for sepsis, and this is one of the reasons that, as Rick said, it was an area of focus at Huntsville. There are other ways to assess the incidence of sepsis. Another way Huntsville looked at their incidence was by DRG. So basically taking the number of DRG sepsis diagnoses, and there are 3 of them listed here, divided by the total number of discharges. And by this calculation, which is always less than by ICD-9 coding, by the way, because you only get a DRG for sepsis if it was present on admission, and it's the most important diagnosis. But at any rate, by using this assessment, the mean rate at Huntsville was about 0.5%, and that would be more than the national average for similar size hospitals. It happens to be fewer, though, than the average hospital in Alabama, just for reference.
A couple of things come to mind when I look at this cartoon. First is change is hard, and the second is timing is everything. Walters Kluwer initially approached us about the concept of this project about a year before we were really ready to do anything about it. Several months later, at a quality council meeting, we were discussing ways to alert nurses and physicians as to the potential onset of sepsis in patients. From that grew some discussions about things that we could do with what I called simple alerts with existing tools that we had in-house. And then around that time, shortly thereafter, coincidentally, WK approached us again. So this time, the pump was primed, and we were ready. We were ready for discussions on the topic. Next slide. As we engaged with Walters Kluwer, we had to organize ourselves on multiple fronts. We created nursing teams, created a physician steering committee. Those two entities were initially focused on education and driving the development of evidence-based protocols and order sets. One of the things that surprised me, now as a non-clinician, I knew the general concept of sepsis, but I didn't understand it very well at all. So I did a little education for myself, just so I knew a little bit more about what we were talking about here. But the thing that surprised me was how little understood sepsis was by nursing and physicians alike. Sitting in on meetings, doing follow-up discussions, talking about the things that we needed to do, and just listening to the outcomes and the results of some of the education processes. Really, like I said, it surprised me to be able to realize how much the educational piece of this was, even as we were beginning to plan the technology aspect. Next slide. Running in parallel with the clinical efforts, we began to organize the technical requirements within IT. To feed the Walters Kluwer clinical analytics engine, we started some of our interface development. We're a best-of-breed shop, and as a result, we've got an interface engine with a number of different types of results and reports and things passing through that on the way back into our EMR. So in a few instances, those interfaces were pretty straightforward and simple. We just basically cloned what we had, and what we were sending into the EMR. We also then sent that on into the WK analytics engine. Some of the other information, such as the nurse documentation, a few things like that, was a little bit more challenging for us to get to and to be able to pull out of the system. Separately and independent of this project, Huntsville Hospital had begun to define what we referred to as a nurse mobility strategy based on iOS devices. We had begun to articulate a goal of putting as much information in a nurse's hands as we could. So we wanted to put more information on handheld devices, more types of capabilities that would reduce some of the sheer travel time that a nurse had to have when she or he needed to look something up, etc. So we articulated that as a goal. Nursing was already carrying pagers that we use from our nurse call system and a communication system to push alerts to and notifications of various types. So one of the things that we did there was to front end the Walters Kluwer Point of Care Advisor application with the patient assignments that were being done in the nurse call system. One more key comment before we leave this slide and move on was when this project came along within IT, like all of you, our resources were pretty stretched. We didn't really have a slot. We didn't really have an opening. We didn't really know how we were going to squeeze this in, but within IT, we discussed this as an opportunity for IT to have a direct impact on patient care, which is kind of rare. We all know that we have indirect impacts in a variety of ways, but we thought this would move us closer to actually being able to provide a direct impact on care. And so the team basically said, you know, we're going to find a way to squeeze this in.
Thanks, Rick. So all the work that Rick talked about that Huntsville did is very important in terms of its collaborative work with what Wolters Kluwer was providing. You can have the best electronic solution in the world, but if the teams don't know what to do with the alerts because they haven't set up protocols, processes, order sets, then it may not be very effective. Plus, you want to get the alerts to the most important people right at the point of care. The mobile strategy that they took on was very important too. From WK's perspective, our primary focus was on the electronic alerting system, and we did a fair amount of study ahead of time of the literature, and there have been about 10 published studies to date that specifically on electronic alerting. And if the basic criteria for sepsis from the IHI Surviving Sepsis campaign are used, then those alerting systems have resulted in sensitive alerts, meaning they catch sepsis, but not very specific alerts, meaning they have poor, there's a lot of alert fatigue. And the end result for most of those studies, clinicians ignore the alerts. There have been a few studies where they've ratcheted up the parameters, which has resulted in better specificity but poor sensitivity, which means that you miss a lot of cases, and therefore most studies published today have not significantly improved mortality through the electronic alerting. We knew that we needed to focus on a system that was both sensitive and specific. In order to do that, it was very important that we got a little more detail out of the EMR that Rick had just recently talked about. So with this initiative, we decided to focus on a system that didn't cause alert fatigue, that was both sensitive and specific, and took into account and collaborated with the change management effort and the protocols that Rick just talked about. And then we conducted a study with a hypothesis that the combination of these change management and an improved, more sophisticated alerting system would result in the reduction of sepsis mortality. So let me take just a minute to talk about WK. We're a large company, more than $4 billion in revenue, with almost 20,000 employees worldwide. Health is one of our 4 verticals. Within the health space, many of you have probably heard of a lot of our products, from UpToDate to Provation to drug reference sources like Lexicon, Metaspan, and we have Sentry7, which is a surveillance engine installed in hundreds of hospitals around the United States, and that is leveraged for this project to pull data out of the EMR and run a rules engine. And we have Health Language, which is our terminology mapping company and product. Here's the infrastructure for what we built. We pull data out of the EHR system using our existing technologies. Key data elements include patient demographic information, vital signs, medications, labs, and very importantly, nursing documentation notes. And again, Rick said that was one of the areas where IT had to do a little bit of development to get an interface for the nursing documentation elements. They happen to be very key because they're used extensively in the rules engine to improve sensitivity and specificity. We then run that data against rules in our cloud, and if a rule is positive, we decide what information that comes from our key reference sources should be pushed back to the point of care. And we built our system so we can push it to many different devices. We know it's very important to get it right to the most important clinicians right at the point of care. We didn't want to just push the alerts into the EMR, or somebody may not see a time-sensitive alert until late. So we built it so it works with lots of mobile devices, including pagers, smartphones, voice over IP phones, communication devices, or just at a regular workstation within a browser. Again, as Rick said, at Huntsville Hospital, the nurses are carrying smart devices, and so we pushed to those devices, and they could actually see all the information right on their person. We send 3 types of alerts. The first and primary type of alert is the diagnosis of sepsis. It comes in lots of different flavors, the core one being a positive sepsis screen, but there's also alerts for severe sepsis with hypotension, septic shock, and a few other varieties. Every one of these types of alerts we expect to be acknowledged either by agreeing or disagreement. If the nursing staff, who are the primary responders, don't agree, then we follow it up with a different alert that I'll talk about in a minute. If staff agree to an alert, then next we send another type of alert that is advice. So this is evidence-based, and it also follows the protocols at the hospital. So in this case, Huntsville, it'll very specifically say, remember to use this order set, or remember to call this person for this scenario, in addition to more specific advice. And then the third type of alert is the close-the-loop reminder alerts. If staff has not responded to an alert, we will send a reminder and another reminder, and we will eventually escalate it to the next most appropriate person, like that, which is usually the charge nurse, to make sure that alerts are not lost. And then we also send alerts for patients that are becoming very ill. We send a reminder, for example, if they have severe sepsis with hypotension. We want to make sure that over time that somebody is rechecking on that patient, that their blood pressure has been rechecked. If it hasn't, we'll send a reminder. We want to make sure that they've received appropriate fluids or IV fluid or IV antibiotics, and that they're transferred to the appropriate location. So if they're still hypotensive, we want to send reminders that they should be going to the ICU and appropriate staff called. Key is to not let patients that are very ill fall through the cracks. And the place where we spent most of our energy was building robust rules that would be accurate. And in our analysis, the main reason other studies have had poor specificity is because many other diseases will cause abnormalities that can mimic sepsis. So, liver disease, heart disease, renal failure, alcohol withdrawal, and many, many other conditions cause basic abnormalities that can cause your average rule that you might implement in your EMR to fire, which would be an erroneous and annoying alert. So what we've done is we've taken documentation from the EMR to understand the comorbidities for patients, both medicines and medicines and medical conditions, and then we run patient-specific rules. So patients that have liver disease get completely different rules run against them, or patients that are on dialysis or are on certain medicines. This allowed us to build a system that was still very sensitive and yet very specific without much alert fatigue. All told, we built more than 200 rules that are looking at different patient-specific variations in order to make sure our system was accurate. And I'm going to take a minute and actually toggle over to a live demo here to show you what the system looks like before I continue. So this is, actually it's a recording of a demo, but it's the software in use. And in this demo, I'm going to log in as the nurse. And so this is what a nurse would see. These three patients are being taken care of by this nurse. Bruce Wayne has an alert. If I click on Bruce Wayne, I see at the top of this screen important data that we've pulled from the EHR that's easy for assessing for sepsis. And down here I see the alert. This patient is screened positive for sepsis, and the software explains why it believes this patient has sepsis. The patient is positive for infection. You'll see by this bacilli symbol, which lines up with this row, that the software believes that because the patient's been diagnosed with pneumonia. And the patient is positive for SIRS. You can see by this lightning row of data here that the patient has two SIRS criteria, fever and bandemia. The patient does not have organ dysfunction, which is evident in this row. So most of the time, the staff will agree with these alerts, but they also are times when they'll want to override it. The software will show you that in just a minute. In addition, you can look at more details around the data, like timestamps for when it was collected. You can also look at trending, and you can look at previous alerts that may have fired on the patient. But in this case, the software demo will next show what the override looks like. So if they do choose to override, we expect them to give a reason. And if there is a chronic condition that wasn't captured by us that is explaining why something is always abnormal, they can check one of those boxes up there, and that will make the system smarter for that patient. It will now understand a new baseline for that patient so that it doesn't continue to fire. But if they acknowledge it, next they get some advice. There's advice that's pushed for what they should do that matches the facility's protocols. Then the software will follow that patient over time. Here's another patient with an alert. This patient has severe sepsis, and you can see the patient has both infection, SIRS, and organ dysfunction. This criteria that are abnormal, and multiple organ dysfunction criteria. So there's more to this demo, and if anyone's interested, we can talk more about the in a different setting, but I'm going to return back to our presentation. So we conducted a study then at Huntsville where it was, as Rick mentioned, it was in 2 wards. One was the respiratory pulmonary care group, which is composed of 2 different wings, and then there was the general medicine floor. And we studied outcome as the primary outcome, and we assessed the control period versus a study period, control period being a time of about 3 years before we started the project. And then the study period was about 10 months after go live of the software. And we asked the Huntsville staff to pull ICD-9 codes on these patients. And then and we chose ICD-9 as the study method because that's commonly used in many other studies, and it doesn't take a lot of resources to do chart review, and it prevents us from having bias when we do chart review of our own, because it's just a query of the billing system. There are some known limitations of ICD-9 for this purpose, the most notable one being that it is frequently sepsis cases are missed by ICD-9 coding. But at any rate, we used ICD-9 coding because it's commonly used in studies. We excluded patients that went right from the from the ED to the ICU and then came to the sepsis screening floors because they received the bulk of their care in the ICU before they were screened by the software. We also excluded people that were on comfort care measures, and that was determined by chart review, just the comfort care component. Here are the next, we then studied the following outcomes: mortality, which was the most important one, but also 30-day readmission rate, length of stay, and later I'll go over test characteristics and bundle compliance. So there were 5,000 plus patients in the control group versus almost 2,000 in the study group. Again, the control period was longer, which is why there were more patients. After we limited it to only those that were on the screening units, then the numbers are smaller. Then we excluded patients that went to the ICU. Then we excluded the patients that had limited care. And this row then is the population of patients that could have been impacted by the software. Again, this is patients on the screening floor that were not comfort care, that did not go to the ICU first. And so we compared those in the control group versus the study group. And this will be used as the denominator for looking at our statistics as we go forward. The first statistic we looked at was the sepsis incidents as measured by ICD-9 coding. And there, you'll see that there's a gradual trend toward more capture of sepsis by ICD-9 code over time, dating all the way back to 2011. It was a pretty gradual increase. So because it predated the study, which means it wasn't our study efforts that caused improved recognition. It had been going way back to 2011. And we believe this is because around that time, 2011, Huntsville started an initiative to do a better job of coding sepsis, and they have a documentation improvement team that that talks to physicians to try to get them to document sepsis, and that's been in place for years, and that's probably the reason for the gradual increase. And you see, in fact, that you see the exact same rate of increase in capture of ICD-9 coding on the non-screening floors, which again suggests that it wasn't the impact of our program that caused an increased capture of ICD-9 codes. Next, our main outcome was sepsis mortality. So we assessed sepsis on the screening floors pre and post, and it dropped by approximately 50%, 53% in fact, and this was statistically significant. We also assessed this mortality not just by ICD-9 codes, again that was our primary denominator for most analysis, but we also did it by 1,000 hospital days. So if you just look at the number of deaths in patients that are coded with an ICD-9 code on the sepsis screening floors, there were 51 deaths over 1,000 days in the control period and only 29 deaths per 1,000 hospital days in the study period. So mortality was dropped by this assessment by 43%. So this would tend to underestimate the deaths because we are going to attribute more deaths in the study period with better ICD-9 recognition, whereas the previous one might slightly overestimate it because, same reason, we might we might capture more ICD-9 deaths in the study period. So the real mortality rate is probably somewhere between 43% and 53% reduction. Now, if you look elsewhere, hospital-wide, outside of the study wards, there was no drop in sepsis deaths. So we don't think that there was just something that was improved at the hospital-wide, or better recognition over time, because it didn't improve hospital-wide. It only improved on the sepsis screening floors, the mortality rate. Secondary analysis, we looked at 30-day readmission rate for patients with an ICD-9 code of sepsis that were on the screening floors that were discharged. And of those patients were readmitted during the control period, and only 13% were readmitted during the study period. So there's a drop in readmission rate of about 30%. And this is statistically significant. We also looked at length of stay, and there is a trend toward a reduction in length of stay on the screening floors. It is not statistically significant, but we believe it will be statistically significant once we have enough data. But there is, at least it's moving in the right direction. There's a trend toward it going down. And if you look hospital-wide, that trend does not exist. So the trend toward reduction in length of stay is only on the sepsis screening units. So, you know, our assessment is that this initiative has reduced mortality and also reduced readmission, 30-day readmission rates. So next, we also looked at the test characteristics. So we didn't use ICD-9 coding for this because it isn't quite accurate enough. Instead, we actually did thorough chart review. We had 3 personnel review every single chart during a 3-month time period and make a clinical diagnosis of sepsis or severe sepsis. We did this independently of the alerting, and then we created a 2x2 table, alerts positive and negative, and sepsis by gold standard positive, negative, and calculated a bunch of results. And I'm going to show results that are outstanding. Again, I mentioned it earlier, but one of the reasons we were able to get such excellent specificity is because we took into account a lot of medical conditions that we knew the patients have, and we built specific rules. This is a pie chart breakdown of a list of conditions that influence sepsis and the frequency that we saw them. We changed the actual names of the conditions to just condition, but the point is that we took into account a lot of different medical conditions in order to get such excellent results. And first, we assessed the positive predictive value. When we went live at first, it wasn't so high, but as we added more medical conditions and built out the rules, the positive predictive value rose until it was at a number that we felt was excellent. And accordingly, the false positives went down, so you won't be getting alert fatigue once you drop your false positive rate down, because staff will trust your alerts. And then we studied the sensitivity and the specificity. So again, reminder, sensitivity is how good your system is at catching sepsis. So only 5% of sepsis cases are missed by the system, and that's very good. Specificity is if directly correlated with alert fatigue, and our system is much higher than any other published result that I'm aware of in both sensitivity and specificity. And so our summary here is that if you build out a system and you take into account a lot of different comorbidities that you pull from the chart and build out lots of rules, you can build a system that's highly sensitive and specific. Last form of analysis is the sepsis bundle compliance. The 4 main treatment bundles that we assessed is ordering a lactate with a positive sepsis screen, ordering blood cultures before antibiotics, then ordering appropriate broad-spectrum antibiotics, and then fluid resuscitation, giving adequate fluid within the first several hours for patients that have hypotension. And we compared the compliance of Huntsville with the average rate from this large study published by Mitchell-Levy et al., which is a series of about 30,000 patients, and we said that they're yellow if they score in the average range, green if they were better than average, red if they're suboptimal. All of these bundle compliance measures improved considerably with the program, and 2 very important ones are considerably better than national averages. There's still room to go in fluid resuscitation at Huntsville, and since this study was ended, Huntsville has continued to work on that effort, and I believe it's probably better today, although we're still waiting for the most recent results. Regardless, the bundle compliance improved over time at Huntsville. We did a very brief analysis also of the financial impact. This wasn't a major focus, but we do know that there is probably a cost reduction with improving length of stay. Perhaps more importantly, the pushing alerts to staff to call out attention for sepsis leads to an improvement in documentation, and that will lead to an improvement in ICD-9 coding and a change in DRG, and that appropriately will result in a revenue capture from more appropriate, specific, correct coding. Our brief assessment is that this impact could be as much as millions of dollars for a hospital the size of Huntsville. So our summary is that regardless of the accuracy of the alerting system and the robustness of protocols, change management is an important part to make sure that the staff continue to deliver the treatments that they're supposed to. But overall, an electronic decision support system and the change management and efforts at Huntsville did lead to improvement of the bundle compliance at Huntsville. So just some limitations of the study. Well, one, it's just a single center. Second, it was restricted to just a few wards, not yet hospital-wide, although as Rick mentioned, since we finished the study, Huntsville is expanding to many more wards. Third, this is a known problem for almost all other sepsis studies, but ICD-9 coding is not the best way for assessing sepsis. And those are the primary limitations of the study. But our conclusion is that implementation of a program that consists of change management, that includes nursing screening, and electronic surveillance system with a system that's very accurate in terms of sensitivity and specificity and delivers alerts to the point of care, can improve sepsis mortality dramatically and some other key outcome measures.
And I want to throw in just one last comment, again from the non-clinician in this whole process here, looking at the statistics and the analysis and everything that's gone into it. The thing that we're convinced of is that there have been patients that have walked out of the facility that otherwise would not have been able to walk out. So we believe it saves lives. That's extremely gratifying for me personally and for all the IT team that's been able to work on this project.
Okay, thank you. Now we'd like to open it up to the audience for questions. As a reminder, please use the questions section on the GoToWebinar panel to submit your questions to Rick and Dr. Claypool. Our first question, how is this different from the capabilities within other EMRs?
I'll take that, Rick, but you can add to it. So, first of all, within most EMRs have good engines for delivering alerts, but they take a lot of work to build. Secondly, most of the alerts are fired inside the EMR, which means they're not seen until someone logs in and goes to the specific patient, so there's a significant time delay. Third, that it's usually an awful lot of work to build out a really robust system like we did with hundreds and hundreds of rules around sepsis. There are very, very few healthcare facilities that probably have the capacity to do that. And then on top of that, most systems don't have the ability to determine to send alerts right to the very specific personnel at the point of care to get them there immediately, and then they don't usually have the ability to track compliance with that alert, to send reminders, to escalate it, and a person that is at the point of care, and then to send different types of alerts related to very specific advice that has to do with a status of the patient. So they don't tend to have the same sophistication that this system built, and nor do healthcare staff have the capacity to build out a system like this.
Yeah, let me just add a couple of comments to that. I mean, from my perspective, it's kind of the classic case of fully integrated applications versus the best of breed approach, which again, as I shared at the top of the conversation, you know, we're a best-of-breed shop, at least today we are. And so when you think about it, especially when you go back, if you think about the slide where Dr. Claypool was commenting on the fact that there were over 200 rules. I don't remember the exact number, but the last I heard, I think it was it was well north of 200. And so if you think about the intellectual capacity that has to go into that, as well as the development to be able to deliver the things that Dr. Claypool just referenced, you know, I think it's a fairly significant difference. I think, again, one guy's perspective there.
Okay, Deborah would like to know if the nursing staff can acknowledge the warnings on the handhelds or just the notifications.
The nursing staff are the primary responders for the alerts, including the acknowledgement alerts. And yes, it was set out at Huntsville and another hospital where we have used the software for nurses to actually either acknowledge or disagree with the alert. So part of the change management effort involves education for nursing staff around sepsis. In fact, even if you're not using an electronic system, it's recommended by the AHI that nurses have training for identification of sepsis, and they do routine screening when they're assessing a patient. They ask themselves, does this patient have sepsis, yes or no? And they make a clinical assessment of whether it's a positive sepsis screen that then kicks off more work. So that's kind of a long answer, but the answer is yes. Nurses actually acknowledge or override a positive sepsis screen. If they acknowledge it, it kicks off the evaluation for that patient.
Along that same line, what education did you provide to the screening units?
So Rick mentioned, and Rick add to my comments, that there were teams. There's nursing unit teams, and then there's sepsis steering committee teams that were responsible for understanding you know, the program that included education. With that, we worked with a third-party change management group that provided a lot of the services and education, and Wolters Kluwer supplied some of the education. But it included grand rounds for all hospital staff, and then it included specific one-on-one training with nurses, and it included even review of sepsis cases, practice cases.
One of the things that I would add to that is as we got into the initial education, we started with a paper version of the screening tool. So as nurses were being, excuse me, as nurses were being educated, and as they initially started putting what they had learned into practice, it was done on paper. So they had the opportunity to learn the concepts and to work with the I'll call them the super users, the folks who were really leading the effort and were the most completely educated on not only the clinical aspects of sepsis itself, but all the things in terms of what our standards relative to policy and process and procedure and such would be. So I think that was a key part of this was bringing them along in a way that they could learn the concepts before you put the calculator in their hands.
When a user acknowledges or overrides, does it go to the EMR for documentation? Is that decision recorded?
No, it's not. So the EMR is the source of truth for everything. So just as if two staff in a hospital might communicate by phone and have a conversation, they should go to the EMR and record what they did. And I think the same expectation is true, you know, at hospitals that are using our program for screening. You know, they should document what they did. We do have the ability, the know-how to send a notice back to the EMR, but we did not do that for this pilot, and we did not do that for our other facility.
Are providers able to build rules into their own EMRs to increase alert accuracy?
Health systems could build alerts out at the EMR. You know, as we talked about when answering the first question, it would be very difficult for a health system to build their own rules that would achieve the accuracy that that we were able to do. We've spent 4 years of research and millions of dollars on understanding all the factors that go into sepsis, and the average health system just isn't going to be able to create hundreds of rules, do rigorous iterative testing, get resources from IT to help build it out. So the answer is, I think even the largest health systems that have a lot of resources are unlikely to be able to create a system that is this accurate.
Yeah, let me add to that as well. Again, at the top of the fact that in a clinical, in a quality meeting, we were talking about the impact of sepsis on our patients and how could we more effectively be alerted and be made aware that that someone needs to look at that as a potential problem with a specific patient. And I mentioned the fact that we considered the idea of creating what I call simple rules. So, we had a couple of conversations about, okay, what could we do internally? What are the basic pieces that we could do that we could create the alerts? And frankly, it didn't take us very long to conclude that there would be so many false alarms, if you will, that we didn't think that made sense. We felt like that we could create some rules, but again, getting back to the sheer volume and the amount of detail that goes into the analytics engine that fires the rules, we knew we could never do that.
Sally would like to know what the system requirements are for a hospital to implement these alerts.
So with the POC Advisor, the WK program, we use an existing one of our products that's installed in hundreds of hospitals around the country. It works with every major EMR, and we traditionally use standard HL7 interfaces, and most of them are already up and running at most health systems. And so they include meds, medications, ADT, for the patient demographic information, and labs. So those are pretty standard. The interfaces that may not be at every hospital is an HL7 interface for vitals. Many have them, others don't. But if they don't, it's an interface that can be created readily. The one interface that is frequently not up and running at most hospitals is one to pull the documentation. And Rick mentioned earlier that was an effort IT had to add at Huntsville. And let me add just a couple more comments, Rick, and then I'll let you add. Other requirements include some form of mobile strategy. It can be minimal. It could be pagers, but we feel it's pretty important to send alerts right to the point of care. We have the technology and the know-how in some EMRs to also send it into the EMR, alerts into the EMR. Those are the main system requirements, but that latter, having devices, might mean that a system, as Rick had talked earlier, might need to figure out what devices staff are going to carry.
Yeah, for us, the key thing is it was fairly straightforward. Again, the analytics engine runs remotely, so we put a VPN in place to establish the HL7 connections and feeding all that, and then the delivery mechanism of the alerts. And we were piggybacking on some of our other strategies and some of the other things that we were trying to do there, moving from pagers to smart devices. Being part of that effort.
Okay. Will you talk about what effect the technology had on the hospital staff's daily routines?
Well, I guess that would come to me initially there. We've had some challenges, mostly because of the changes in the device. Like I said, our pagers, our nursing staff have been carrying pagers for years. Some of them also carry some type of a phone. We've got a variety of things. We've got Voceras and SpectraLinks and ASCOMs, and we've got a variety of technologies depending on the area of the hospital, et cetera. So as we started trying to look at ways to basically, we've joked about the bandolera that nurses have to carry around with different devices strapped onto them. We wanted to collapse that, and so that's been the biggest issue. Really, is making that work, and a lot of it is not so much the alerts from WK perspective, but just the issues with those devices. A key component I might mention, though, is the fact that you do have to have assignments. So as nurses are given their assignments at the beginning of the shift, they have to identify that in some manner. Initially, our nurses were doing that through nurse call and also through the WK applications. But then we were able to create some integration and some interface between our nurse call system and WK, so that we could simplify that, so that they only had to do their assignment once and the information flowed through.
You know, just this question might have come about also because of the person asking the question might be concerned about whether nurses, you know, tolerate an extra duty of carrying a device around and answering it. And I'll say that I've been very pleasantly impressed by how the staff have really embraced the technology and the system. And I think it's because they see it really helping. They don't get very many alerts, and they only get alerts when patients are sick, and it helps them where it's not, you know, disruptive, because they feel like it's really helping them in their care of taking care of the patient. And, you know, the first day there's often grumbling that they have something new. In working with the staff, we've seen that they've really embraced it at Huntsville.
Okay, our last question, specifically, what clinically actionable decisions were responsible for the decrease in mortality rates?
I think the most important one was early detection. So if you think about it, the main ways that you're going to drop sepsis mortality is, number one, getting antibiotics early. There's been a couple studies that show that, you know, even short delays before patients receive antibiotics result in increased mortality rates. So every hour matters. And then the second one is volume resuscitation. For patients that are hypotension, you need to first get them fluid, and you need to get it pretty quickly. Those two things are the first ways that you improve mortality, and then after that you get them to the ICU and get, you know, more extensive care. But the best way to get those two things, antibiotics early and fluid early, is to catch them early, catch the patients early. And we know that our system is catching sepsis very, very early. It's as soon as the abnormalities exist in the EMR, which is much, much sooner than staff will have a tendency to just naturally notice. So I'm very convinced it's hours earlier, and that's the main way. Now, the second way is that we do push advice to make sure that they don't forget that the patient is ill, and so that they tend to follow up with whatever they're going to do. We try to remind them to do the right thing. So I think we're also improving the rates of treatment. But of those, it's early detection that I think had the biggest outcome.
Okay, thank you. As I said, that was our last question, so we'll be concluding the webinar. Thank you for joining us today, and thank you, Rick and Dr. Claypool, for an interesting and informative presentation. As a reminder to attendees, watch your email for links to the recording of today's webinar, as well as a PDF version of the PowerPoint presentation. We look forward to seeing you at our next HIS Talk webinar, and I wish you all a pleasant rest of the day.